This case was a 61-year-old male. He presented after a fall. His initial GCS was 14. And in the ED, he actually began to deteriorate, and his GCS fell to 10. My focus is not really on this aspect of his care. You can see he has this temporal lobe hematoma, was taken to the OR, and that was taken out. He actually came back up to the ICU. He was doing relatively well, and 3 days after injury, his GCS was ranging between 11 and 12. He was on low levels of sedation. And this is a question that we could discuss, is that he had really initially a mild head injury by GCS of 14, went to surgery when he deteriorated. He was, from that point on, a moderate, complicated moderate, if you want to call it, and he was still on anticonvulsants. At day 3, there was some concern were the anticonvulsants making him a little bit less responsive, so we went ahead and chose to stop them. Does anyone want to comment on that? He had not had a seizure at this time. He was on Keppra, and an older gentleman, he was on levetiracetam 500 milligrams twice a day.
Why Keppra? Why not Dilantin?
Because of our work that we did here, where when we compared the two, we found that there were fewer side effects with levetiracetam. And I can talk about that later on, or I'll talk about it right now, but we did a direct head-to-head comparison between the two, and in 46 TBI patients, and found that the patients on levetiracetam actually had fewer side effects while they were on medication. And then when we looked at their long-term outcomes, the group that had been on levetiracetam during the hospitalization actually had better outcomes by GOSE and DRS at 6 months.
So the concern I have, Lori, this is Rocco, is that maybe the dose is low, and maybe in fact he's having a non-convulsive type seizures that you're not being able to pick up at this point. This is very leptogenic cortex, the temporal lobe, and my concern is that it may not necessarily present, obvious tonic-clonic seizures, but just with decreased responsiveness, a change in sensorium.
So how long would you keep him on, Rocco?
It's a little bit different with penetrating injuries. We keep them on much longer, but I think for a patient like this that has temporal lobe contusions, I would do at least a minimum of a week. And he's only 3 days post-op.
Yeah.
Or post-injury.
Yeah.
So I think that's a little early to stop the AEDs.
Mm-hmm. And
I think in my mind, that's like when they really start to swell, when all those bad things start happening by, 72 to 96 hours out. That's when they really start getting into the storm.
And again, I agree with Rocco based on the mostly the studies out of Seattle and some out of Kentucky, but probably the Seattle ones are arguably the best, where they actually looked at Dilantin and measured serum levels, and that's where we got the number about 8 days. The prophylactic anticonvulsants help during the first 8 days. After that, if you've never had a seizure, there's no benefit one way or the other. So most people just round it down to a week. A week of anticonvulsants, and if they not have a seizure, then you stop.
Yeah, and we do that for all of our severes. But the question was, he was moderate, but Rocco brings up the epileptogenic focus. Craig, do you, Dr. Rob?
Yes.
Would you do the same, or?
Pardon me?
Would you keep him on 7 days, or?
That's typically what we do.
Yeah. Well, the interesting thing with him is we decided to stop it and take a chance. I figure if they're going to seize, I want to see it. But I got kind of talked into it. Typically, we do 7 days. The next day, his GCS was actually worse. He started having, he really was on minimal sedation at that point. We got an EEG, and it doesn't look too bad. I don't know. Can you all, let me see if I can bring up. This area is something we would call an epileptiform discharge, and it is in the right central parietal area. That is at 7:30 at night. At 2100, you start seeing these begin to be a little more prominent and begin to recognize that there's something rhythmic developing. And by 2150, we're getting this very rhythmic kind of, you can almost see a spike and slow wave in here. And he is not having any motor movement with this at all. So this is just seen on the EEG. There is no motoric component at all for him.
So do you have an alarm on your EEG that goes off, or does an epileptologist see this at this point, or is the nurse able to identify that this is abnormal, or how does it work?
We have we've taught our nurses to identify a change in background like this, and they would call our intensivist, and we take a first look at it. All of our EEGs, we have the ability to view remotely. So we took an initial look at it. I was suspicious for it. Actually, I was pretty certain with this one. But other times, if it's less clear, we have an epileptologist on call. So to get through this relatively quickly, should they be treated, we decided to. We actually gave him 2 milligrams of Ativan. You can see right here where it was infused, and the EEG begins to level back out. He then was loaded with 1,000 of levetiracetam, and by about 15 minutes later, we have back to a pretty normal appearing EEG. This is a little bit of a breach rhythm, a little more attenuation of activity because they had left a small bone flap off. And by the next day, he was back. He actually was localizing again.
Or was he intubated before this?
Yes, he had still been intubated.
He was. Okay.
Yeah. So I just wanted to touch on the fact that there's now been at least 3 studies specific to TBI showing that there is an incidence of seizures, and all of these patients were actually on therapeutic doses of anticonvulsants when they were found to be seizing. The majority of them were all non-convulsive, so you wouldn't have picked it up without the EEG. And the range was anywhere between 17 to 24% of the patients who are having seizures. So peak incidence is right about the 3-day, 48 to 72 hours. Typically, that's how long we monitor on EEG. This gentleman was still on EEG because I knew we were stopping anticonvulsants about a day earlier, a couple days earlier than we normally would, so I wanted to keep the EEG running, which is why we were able to capture this. And if they matter, there's always an argument, do seizures really matter in patients, or do those non-convulsive seizures, is it no big deal? This is work done by Paul Vespa. It was moderate to severe TBI patients, granted only 20 of them, but they did continuous EEG and microdialysis for 7 days. Seizures were in 10 of them. And the interesting thing is the patients who seized had higher ICPs, and they had higher lactate pyruvate ratios, and those were consistent or maintained for about 5 days. And on follow-up MRIs, they actually saw a change in patients that had not had temporal lobe hippocampal injury. They found that those patients on their follow-up MRIs now showed hippocampal atrophy and brain atrophy. And this is just a graph showing the ICP ranges of the patients with seizures versus those without. So I think we have to maintain some awareness. I think people are more and more aware of the fact that these patients can easily seize. The hard part is how to justify the resources needed to monitor these patients consistently. So any comments from anyone on what you would do with that? I know actually I have it here as far as the prophylaxis. You don't really need prolonged AEDs if they are not actively seizing. A severe 7 days, mild to moderate, it's kind of up to you, but many people will follow the guidelines, particularly if there's injury to the temporal lobes because of concern for how epileptogenic that area is. And as far as prophylaxis, phenytoin is what has initially been reported. There's more data coming out on levetiracetam, but these were the results of our actual study with a total of 52 patients total, but 46 of them were TBI. The other 6 were subarachnoid hemorrhage, and showed that there was general neurologic depression in the phenytoin group and more GI problems in the phenytoin group, and then better outcomes at 6 months in the levetiracetam group. So just some things to think about for the patients in the ICU.
Okay, thank you. Again, if there's any questions from attendees, feel free to submit them in the Q&A. Otherwise, does anyone else have any questions for Dr. Shutter about the use of EEG monitoring for brain-injured patients in the ICU? Or comments?
Just Laura, this is Rocco, from a practical standpoint, if you're taking these patients on road trips for other studies, how do you coordinate that with the monitors? Do you use, what type of scalp electrodes are you using? Are you using needles? Are you using?
We're attaching with colloidal glue, and we actually have invested in MRI-compatible EEG electrodes. The advantage of these is that they are grouped together, so it's a simple. First of all, they don't produce as much artifact on CT or MRI. Second, the way they're set up is that it's a simple plug-in. All of the leads are kind of braided together, and it's just 2 plugs that you put into 2 cords. So you unplug all of the EEG electrodes just from 2 different circuits, 2 different cables, and then we'll kind of wrap those up to transport the patient, put the machine on hold, bring them back, and plug them right back in. It's actually pretty easy. You don't have to. You used to have to pull out all 20 little wires or carry or disconnect the EEG box from the machine and carry the EEG box on the bed with you. Now it's a simple cable that just can be unplugged. The resources are pretty extensive to get involved with EEGs but we found that actually paid for itself. I just saw one question come up of, do we have any recommendations on the choice of drug or drugs if a patient has seizures despite standard Keppra dosing? We actually will push Keppra up as high as 2,000 milligrams twice a day. After that, we're going to add additional drugs. Typically, we go to IV agents. Phenytoin is still a popular favorite. And if that one, if there's contraindications to using it or problems with phenytoin and Keppra combination, then we'll begin to look at other options. And next steps, I actually used to go to Depakote, but some of the Depakon, the IV form, some of the problems with drug-drug interactions, moving away from that, and there's a newer drug that has come out called lacosamide, Vimpat, that has an IV formulation that's very well tolerated and not sedating. That's an option, or phenobarbital, the old standard. I've used those. If the patient is in status epilepticus, they're seizing continuously, we're going to go to a continuous IV infusion of either a barbiturate or Versed to stop the seizures.